Hi guys. Talk about a letdown. We have a really great COVID vaccine discussion, and now we're talking about feet. So sorry about that. I thought that was really great. I wish that everyone out there could get information like we all just got. I think misinformation is a problem, as we all recognize. I actually got a text this morning, last night late actually, from a distant family member that asked me if it's true that doctors get $50,000 for every 200 vaccinations they give. And this was a real text, this was not a joke. So I haven't seen my check. I don't know if you guys have, but. Okay, my name is Jason Bruse. I've been in this community for 18 years or so. I initially started, I was hired at a residency at McKay Hospital, worked with Jack Wallen for years in his diabetes clinic at McKay, and then I started, helped start the McKay foot and ankle clinic. And I was there for several years, and then I moved over to the Ogden clinic, so now I'm over in Layton in the Ogden clinic. I'd like to talk today about, we're going to talk about podiatry and wound care, and kind of walk through. I think it's very helpful sometimes to talk about the problems that we treat as podiatrists, because there is some misinformation. There's also just flat out people just don't know. And so these are probably in order the things that I see in my office. Heel pain and plantar fasciitis is by far the number one thing that I see, and I'm going to walk everyone through that very quickly, because it's very likely there are probably 10 people in this room right now who have it. And so we'll kind of walk through if you came to my office today, here's what I would tell you. I see lots of foot and ankle fractures, ankle sprains, tendonitis. In the more involved cases that we do, flat foot reconstruction, cavus reconstruction. I do a lot of bunions, and I'm going to talk about that in a minute. I do see kids, and there are some things that we do for kids. There's really good data that shows that if a kid is born with a flat foot, a really flat foot, it can cause sequelae of problems as they get older. So if you've got a really flat foot, just very elementary explanation, but if you've got a really flat foot, which tends to be genetic, your lower leg bone, your tibia bone, twists inward with each step, and your knee bone really, or your femur really doesn't. And so there's a twisting moment that happens at the knee with a really flat foot that just extends on up the chain. And so patients will get problems even in their teens and their 20s, and it gets worse with each decade as people gain more weight and become less active. And so we do try to at least combat flat feet with what we can do. I'm pretty conservative, obviously, when it comes to younger patients, but there are some things that we can do with foot supports, and there are a few procedures that we do to help out. Neuromas, I'm going to take a minute and a slide on neuromas, because that's very common. Also, another problem that there's very likely some people in this room that have right now, so we'll talk about that. We see lots of skin problems, and that's really where diabetes comes into play. And so I'm going to talk a little bit about diabetes and really what, for the primary care providers in this room, about the things that you see that really should be sent on to a podiatrist or someone really interested in treating diabetic feet. There definitely are some warning signs, and so we'll talk about that. So let's talk about bunions very quickly. There's some etiology. It's really about 1 out of 3. Women always ask me, I get asked every day if it comes from high heels, and it doesn't, but it does happen to patients. It's more symptomatic in women, and it's more symptomatic in people who wear really narrow shoes. And so I'll show you what a bunion is. They do hurt. Everyone probably in here knows what a bunion is. It's a lump that forms on the inside of your big toe joint, on the inside of the first metatarsal bone. It causes a lot of instability throughout the foot, and so it's not just a lump there. But women's shoes tend to be more narrow, and so they have a harder time. If a woman has a bunion, she has a harder time getting through life than a guy does. And so, because guys can buy wider shoes, and women have a harder time finding that. And so they're essentially a surgical problem at some point when it gets bad enough that the patients can't deal with it. And I talk patients out of surgery every day in my office. and tell them, look, that's, my speech is very, I hope it's a speech of a lot of podiatrists out there, but my speech is, look, if the problem that you have right now is not interfering with your life, preventing you, the example I give is, if you like to take your dog on a walk every day, and if you can't take that dog on that walk because your bunion hurts so bad, well, then let's fix it, because it's a fixable problem, and then you can get back to your life and the things you like to do, and that affects your happiness level and satisfaction in life and your happiness quotient. And so but that's the reason to have surgery. You don't have surgery just because of an X-ray, or even cosmesis does matter to some degree, but really I try to aim for patients who really it's painful and interfering with their life. So this is a really great, if you guys are back there, you might have to push play on that slide. Can you push? I don't have a mouse here that will get there. This is a really great animation. Is there a way that you guys can do that or no? If you mouse over to the bottom of that slide, there's a little animation. This is an animation if we can show it. There we go. Perfect. Thank you. So this is really great. I didn't make this, but I love it. I've had it for about 15 years. This shows what a bunion actually is. It's pretty complex. And a bunion is really a deviation of your first metatarsal bone rolling out. It rolls out and away from the rest of the foot. And it's a pretty complex happening. And the other thing that happens that you see here, patients obviously get a big bump on the inside of their big toe joint, but they also have significant pain on the rest of the foot. And so it's not just hard to find shoes from the inside of their bump. It really disrupts the entire mechanism of how their foot functions. And so it's a pretty complex problem to fix this. And this is a good indication of how this happens. This is your first metatarsal bone, as everybody remembers. A bunion, I believe, and there's a lot of evidence recently suggests that corresponds with this, a bunion is actually caused in most cases by a weakness right here of the first tarsal metatarsal joint, which is this joint here. This joint is loose, causing this whole bone to be able to migrate and roll inward, and that's a problem. And what happens in these patients is this joint is loose, therefore this whole bone does not bear body weight very well. Your first metatarsal bone should be bearing about 60% of your body weight. Most of your body weight then is spread amongst the lesser metatarsal bones. Well, if this bone is really loose at the tarsal metatarsal joint connection here, then most of the body weight then gets immediately thrown to the lesser metatarsals. And patients oftentimes with a bunion actually have pain under their second toe. And that's a real red flag, and they need to, consider doing something. So it's not just the bump. It's not just the toe banging into the next toe. It's really patients, their whole foot function is disrupted, and so they'll get a lot of pain under the second and third toes as well. So it's a pretty complex problem. So this is my fix. So this is a patient, a post-op, and this is the other foot that we had not done yet, so you can just see a good comparison. So the answer, in my opinion, for most patients is to actually go back here, and this is a pre-op x-ray here, and actually roll this first metatarsal bone back and fuse this joint. So we actually fuse it. I do it with, this is a fixation device that we can do percutaneously, basically with a minimal incision. And it fuses that first tarsal metatarsal joint. This is the fix that the bunion cannot come back. And I'm sure everyone in your office has someone comes in and they get a bunion surgery, and then 2 or 3 years later they say their bunion came back. And when that happens, usually what the doctor has done is done a slice off of the bone right here and maybe just cut the bone in half here and slid the tip of the metatarsal over. And in my opinion, in most people, that's the wrong surgery, and you see the real problem is back here. And so there's a lot of evidence that suggests that that's the way the bunion should be handled, and this is really the direction that things are headed, which I am in favor of. So here's another x-ray, and you can see, again, the bone out of position here. These are the sesamoid bones that, if you aren't familiar with those, everybody has them. Nobody knows they have them. They're like little kneecaps. And they should be sitting directly underneath the first metatarsal bone. That's one of the targets of a good bunion correction, is did we get them back underneath. So again, this is the fixation device that we use to do this and fuse that first metatarsal phalangeal, or first metatarsal cuneiform joint. And if this is fused, if it does fuse well, then this patient really shouldn't be able to get that bunion back again. It makes her foot function much better. So this is the demonstration of kind of the bunion surgery that actually is probably still more prevalent and I think is probably waning, but this is the surgery. So a doctor will slice off the bump and then cut the bone and slide it over and then put a couple screws in to hold just the tip of the bone. You can see in this patient, this may actually work long-term because the sesamoids are well aligned now. So it's not that every one of these surgeries fail, but there's some studies that suggest up to 2/3 of these over time will fail. And so this is a surgery. This one, in my opinion, probably will be successful, but most patients who have this surgery long-term, I think, will not be successful. So that's kind of another picture of the same surgery. So, and this is kind of what happens to the bone if it's crooked here, but then we just cut the tip and slide it over. That's just not a great picture, in my opinion. So, another thing that we can do is another problem that I see a lot is we see a lot of arthritis of big toe joints. So we can replace these joints, or we can fuse these joints. We can fuse these joints. If you see someone who's got a lot of jamming in their big toe joint, this is a really common problem. It's a problem that a lot of patients have that, I'm just getting my notes here. And we see this problem a lot. So kind of the two options for this problem is to fuse their big toe joint or to replace the joint. Fusing the big toe joint sounds awful. It's really not as bad as it sounds. It's a little hard on patients who are like plumbers or have to do a lot of squatting and kneeling down, and in their job it's a little hard for them to do that. But there are patients who have been runners, marathon runners, and with a fused big toe joint. So it's not the end of the world. And so if you encounter a patient worried about that, it's definitely a better problem than dealing with a big toe joint that hurts all the time. Okay, here we go. So plantar fasciitis is, again, this is a problem that I see all day long. And in essence, the simple explanation is your plantar fascia is this big strong ligament from the bottom of your heel bone that runs to the front of your foot. We think in most cases it's a small tearing of the ligament, usually the ligament on the inside, the inside fibers nearest the medial aspect of the heel. Those fibers tend to be the tightest, and they tend to kind of give over time. We think it happens kind of to bring I don't know if you've read the book Born to Run that came out about 15 years ago, but there's a big barefoot running craze, and in that book it talks about the theory behind running injuries and people who wear shoes all the time. One of the things that happens wearing shoes all the time is we believe that the intrinsic musculature of the arch gets weakened a bit because the muscles are not having to work as hard. So in societies that wear shoes their whole life, the intrinsic musculature gets a little weakened, and so as time goes by and your arch begins to collapse a little with age, that musculature is not strong enough to catch the arch and lift it back up. And so what happens is the plantar fascia catches all of the weight of the patient, and then the plantar fascia starts to tear a little bit. And so that's what we think happens, and there are some good studies that demonstrate if you take a tribe, some indigenous tribe, somewhere who never has worn shoes, plantar fasciitis is not a problem for them because it's probably related to this intrinsic musculature kind of becoming weak over time. So we think it's a little bit of a tear, and the problem when you're getting a little tear in this tissue is, this is the typical explanation, as everyone in here probably knows, but you go to bed at night, when you're in bed, your foot totally relaxes, and there's no tension on your plantar fascia when you're in bed. So those small tears in that plantar fascia, they probably come together and try to heal themselves overnight a little bit. Now this tissue can heal itself, but it's really slow. And so it takes several weeks for it to heal back together, and when it does heal back together, it's pretty delicate, and so it's definitely not going to heal back together completely overnight. It probably takes 3 or 4 weeks to do it. So the patient goes to bed, lays down after walking on their foot all day, the arch is relaxed, the tissue ends probably come together and try to heal. As soon as they get out of bed in the morning, they step on their foot and re-tear it again. And so this is the most frustrating thing about patients, for patients with plantar fasciitis, is that they can never get it better, and they keep trying different things, and they look on the internet, and they try rolling a frozen water bottle, and they try everything they can find. Most of the time, it's because they're re-injuring it all the time, like a fresh new tear every morning. Same thing happens throughout the day. If they'll walk around, the way you get plantar fasciitis better, and I'll show on the next slide, is you kind of have to hold your arch in the same position all day long, kind of 24 hours a day. And if you can do that, and there are ways to do that, but if you do that, the tissue never really re-tears, and that's what we're trying to stop, are these re-tear episodes, and especially every morning. And so if you can do that, it can get better. For me, in my practice, I only do surgery maybe on 1 out of 20 of these, because most people, we can give them our program, and they will get better. So this is the program. So if you had an appointment today with me for plantar fasciitis, don't come, because here you go. So I have people stretch 15 times a day. We think that your Achilles tendon, your gastroc muscle and soleus muscle, your calf muscles, they're directly connected to your plantar fascia, and if it's too tight, that's a problem. And so we tell people to stretch 10 or 15 times a day with this stretch, and this stretch works well too. Then I tell them to grab some kind of an arch support. The brand that we sell in our office, which is available online or on Amazon, is called Power Step, but there are other brands that work. I just like this one the best. But you've got to have an arch support in your shoe, and it has to be something that holds up the arch. Most of the things that you buy over the counter at like Walgreens or at a grocery store is really soft and foamy. It's much more like a pad than it is something structural. We want something structural here to hold up the arch, and so something structural that holds up the arch that is comfortable. You don't necessarily have to go down to that store that's in a lot of malls that costs $1,500 to get a pair of arch supports. You can buy something, for $30 or $40 or $50 that works pretty well. And then this is the part that I leave to the last in my office, because patients like this the least, but you have to wear something overnight to stretch you out, because the nighttime problem is a problem. If they're in bed for 8 hours a day, and their foot is totally relaxed, it's healing in that time in the wrong position. So I get patients to wear this torture sock, is what I call it, and it holds their foot at 90 degrees while they sleep. And so what happens is you heal throughout the day and never have these re-tearing episodes with the good arch support. And then you stretch all day long, you can ice it as well. And then and the other key is that you cannot go barefoot. If you take that arch support out and walk around barefoot, even for an hour in the evening time, you'll tear it again, and we're starting over. And then at night you go to bed, you put on this awful sock, and it holds you stretched out all night long. And then what's happening is you're healing and continuing to heal, kind of this building, and over 2 or 3 weeks of time, the tissue can heal. And so that's what we're aiming to do. And so all of this stuff is available over the counter, and this is the speech that I give. All right, we'll move on, because I'm going to run out of time here. So ankle instability is something that we see often, and everyone probably knows this, but the main ligament one of the main ligaments that holds together your ankle is torn very easily, torn very often in athletes and non-athletes as well. If that ligament is torn, and it happens sometimes even with one bad ankle sprain, if that happens, oftentimes the ATF ligament never fully reforms and never fully heals, and in that situation the patient is kind of left with an unstable ankle really for the rest of their life, and they can walk and do things and run, and there are a bunch of NBA players probably playing with a torn ligament, but their ankle is a little bit looser, their foot is a little bit looser inside their ankle, and it causes scar tissue and things inside the ankle. So this is something that we address quite a bit in surgery. It's fixable. We put a scope in there, clean out their ankle, and we can tie that ligament back together. Morton's neuroma is very common. Can you guys, this is another animation, if you can click on that again. This is a great animation. I wish it went a little faster, but Morton's neuroma is usually in the third interspace here between the third and fourth metatarsal. Everyone in here probably has heard of this as well. This is a pinched nerve between the metatarsal bones and between this intermetatarsal ligament right here, and the nerve is pictured in purple. It just happens to anatomically be a little bit larger nerve than the other nerves in the area, and it gets pinched, especially women who are wearing more narrow shoes on a day-to-day basis. The nerve gets pinched and actually grows into this thing. And patients will say to you, it feels like there's a thing in there. It feels like a big lump in my foot. And that's true, because there is a lump in their foot. And it's just really a really angry nerve. It's not a tumor. It's not a growth. It's not cancerous. It's not anything like that. It's just a really angry, irritated nerve that grows into this thing. So in that situation, you can try to put arch supports and pads in the shoes. Oftentimes that is unsuccessful. We can give steroid injections, and I usually like to actually inject a dehydrogenated alcohol into the nerve with ultrasound. Oftentimes that'll basically kill the nerve in place, but if we can't do that, we will take them out in surgery. So this is another common thing that we see. And patients always ask, well, if you go and take that nerve out, am I numb? And this is just a sensory nerve. It does not control any, proprioception, balance, muscle, anything like that. So really what happens after a nerve surgery, after a neuroma surgery, is that the skin between the toes is a little bit numb. But over time, I've actually noticed that patients actually get a little bit of sensation back. And so it is a good surgery for patients who need it. Plantar warts, I see them a lot. Everyone in here probably has a treatment for plantar warts. We believe it's HPV 11 and 19. In many cases, they actually get better with time if patients are patient enough with it. But a lot of times on the bottom of your foot, they will hurt, and the skin is so thick down there that oftentimes just freezing a wart on the bottom of someone's foot doesn't really even get to the problem. And so I actually use this little Dermajet, which is a little dermatology little gun. It's an air gun, and I blow yeast into the skin and candida into the skin, and it'll oftentimes cause a little immune reaction. The body will then come and recognize the virus, and it works pretty well. But there are a lot of treatments for warts, as you probably know, and that's because nothing really works that great. I'm very, very hesitant to go cut things out on the bottom of the foot, especially warts, because if you violate the dermis layer and then you get a big scar down there in healing, oftentimes that scar hurts as much as the wart ever did. And so I usually have pretty good success with conservative treatments here. Corns and calluses, this gets into our diabetes talk. Corns and calluses are not good. People sometimes think they are good, but they're not. And so they're not padding. They form in areas where there's wear spots, right? And so a non-diabetic who has full sensation will not tolerate a big heavy corn. It'll bug them, and they'll shave it down. But oftentimes a diabetic can't feel that, and so they will simply won't do anything about it. And that tends to be the areas where patients will end up getting a diabetic foot infection, or diabetic foot ulcer. So patients who have corns and calluses and they have diabetes, we're pretty aggressive about trying to educate those patients to shave those corns and calluses down. You can go see a doctor and have the doctor do it. Medicare and your insurance will pay for that. But those are the areas that patients will get problems. And so patients who have diabetes who are in my office, I always like to point out to them, look, you got to watch everything, but if you're going to watch one thing, watch this spot. Watch underneath this second toe. This is the spot that if you ever had a problem, this is where it would be. And so corns and calluses are not great. And really, 99% of the work to get rid of corns and calluses is just mechanical, shaving them down with various different sandpapers or pumice stones or things like that. They're not creams that are great to do this, and I'm pretty hesitant to do that. I just tell patients a little elbow grease is what you need. Tinea pedis is a pretty extreme case because when we show derm slides, we like to show the most extreme. So typically my experience is that with teenagers, they're not good, as you all know, at doing medicines, and so a lot of times I'll give oral medications for tinea, even in teens, because they're not good at all of the things that you have to do. But if the patient will be compliant, over-the-counter stuff usually works pretty well. You have to remember the things that fungus likes. Fungus likes warm and dark and moist, and so that is inside of someone's shoes, right? And so if the patient will be good about getting air and light to their feet, be good about getting a moisture-wicking sock to get moisture away from their skin. A lot of people think erroneously that cotton socks are the best, and they're not, right? And so if we can get moisture away from their feet, get more light and air to their feet. And the topical stuff usually works pretty well. And so most of the time for tinea pedis, I just do topicals for a while. Sometimes there'll be prescription, but a lot of times it's even over the counter and just educating. And then, swapping out shoes if they're wet and that kind of a thing. Onychomycosis, I see a lot of this, and really the only reliable things, there's only really 3 really reliable things. You can get rid of the nail, which is probably the most reliable, and that happens a lot in my office. If someone has a big thick nail that looks like a ram's horn, it's just better to be without it. And so we'll numb them up and pull off the nail and burn it, and so they don't have it anymore. That is an answer. But if it's a younger patient, or 20s or 30s, and they have a fungus toenail, especially women, they don't like that, and so we'll treat it. And we have Lamisil, terbinafine, which everyone is aware of here. The patients are generally very, very wary of Lamisil because of the liver complications. In my experience, and maybe some of you would have different experience, but my experience, I've really only seen one case ever that we were really worried about liver complications. And so sometimes the liver enzymes will bump a little bit, but it's something that we manage. And Lamisil, the safety efficacy and the safety profile of that drug has actually been improved upon since it came out. We were much more scared when it first came out than we are now. So we just draw LFT and we give Lamisil. It just doesn't work that great, in my opinion. It only 60-70% success, and that's consistent with what the literature says. There's also laser as well, and laser costs money. Insurance does not cover that because it's considered cosmetic. But we do have a laser in our office, and we will and have patients go through a laser treatment. And that works actually probably better than anything else, but it's not covered by insurance. Ingrown toenails, I'll see probably 3 or 4 today in my office, so it's usually caused by teenagers trimming their nails too short or rounding the corners. And so it's a lot of education, and then if they have an infection, I'll give them an antibiotic, and then I'll do a little procedure, numb up their toe, and take out just the side, and we usually will put phenol down there and kill just the chunk of the nail that was digging into the skin. These can be problematic. Some people, it's very genetic. It's not always because of how the kids are trimming their toes. A lot of times it's really the shape of their nail. A really wide front of the nail is a problem. Sometimes a toe that's headed the wrong direction. If the big toe is headed towards the second toe, there's pinching that happens there. And that's something that the kid is not causing. But most ingrown toenails I see in teenagers, I'll do 5 or 10 a day. Let's talk a little bit specifically about diabetes now. The cost of diabetic treatments, 1/3 of the total treatment cost for diabetes is due to diabetic foot ulcers. It's a major thing, right? And we all know this. I actually had another slide, but I thought it was supposed to go before this, but I may have added it later to this lecture. But there is pretty good evidence that if we can have a coordinated effort when we admit patients to the hospital with diabetes, there's pretty good evidence that if we can have at least one person in charge of, look, this is diabetic foot infection, let's kind of run through the same hospital protocols, and whoever that patient may be, whether it be a physician assistant, nurse practitioner, podiatrist, or someone really interested in diabetes foot problems, if there's one central person that every admission can run through, not that they're admitting them all or handling every detail, but running them through a protocol, that does show. There's a lot of studies that show that can save, hundreds of thousands of dollars a year in a hospital system and decrease time of admission for patients. And so we like to have consistency and encourage consistency. And frankly, podiatrists, if you have a podiatrist in your system, in your hospital, they should be good at this. And so that would be someone that you could take advantage of there. As we know, major amputation for a foot, for a loss, like a beak amputation, the 5-year survival rate or the 3-year survival rate is 50%. I mean, that's worse than a lot of cancers that we deal with. Medicare will pay for a diabetic to go see a podiatrist and another care provider to go and have their nails trimmed and calluses taken care of, and that can happen every 61 days. The patient doesn't need a doctor to trim their toenails, but what it does is it gets that diabetic patient in front of my face every 2 months, and then I can look at everything. By far, the biggest problem with diabetes is neglect, by far. And if you could remember one thing from my lecture today, besides the gross pictures, would be that diabetics, when things go south, it's from neglect. Most of the time, they didn't think it was a big deal, or they didn't even know something was happening down there. And they stepped on something a few days ago, and they didn't even know. And 3 or 4 days later, we're in the ER, and I get called in the middle of the night. And those things can be avoided if someone will check their feet every day. If they can't see their feet, someone with them check their feet. Get a mirror, someone looking at it. It's neglect. It's not checking their feet all the time. Even if a patient has frank neuropathy and they cannot feel anything in their foot, if someone's looking every day and kind of the commonsensical things of like wearing white socks, because if they got blood on their foot, somehow if they got a cut, they would see this blood on the sock, or if there's blood on the floor in the bathroom, if someone's looking at their feet every day, just those commonsensical things can prevent some major problems to someone during their lifetime. This a couple of interesting studies. This is a controversial paper I wanted to show. This paper showed no connection with A1C and wound healing. I think it was I think most doctors would disagree with this. Most of us won't do like an elective foot procedure in an A1C over about 8, and at least it should be something that we consider and look at. And there is some controversy about this topic, but we generally will look at this, and as everyone knows here, patients who have poor A1C, that corresponds with poor control of a lot of different problems. There's a couple of cutting-edge things that I wanted to briefly talk about. We believe that macrophage research is important for diabetic wound care. As it says here on the slide, macrophages at first create an inflammatory response in a wound, and they'll eliminate the pathogens in the wound. But then they do this specific protein, SETB2, converts macrophages to non-inflammatory repair mode to promote healing. And we think that in some diabetics that conversion never happens, and so that is something that there's a lot of research going towards. If we can help make that conversion happen, we believe that there's a pathway behind this SETB2 that could be important in wound healing, and so that is an area of focus, and this is a slide that kind of demonstrates that. I believe I'm getting near the end here. Yeah, I am. Could you push play on this real quick? This is a great little slide to end with. This is a patient who is going to demonstrate. Can you guys push play on that, on this little, I don't know if it's going to go if I do it. No, it's not. I think this is another little video. Can you guys push play on that, or no? Maybe it won't go. It's a great video. I want you to see it. Okay, here we go. So it's important, exercise and stay active. He's going to demonstrate the plantar fascia stretch right here. That's how you stretch for plantar fasciitis right there. Okay, that's all I have. If there's time for questions, I'm happy to take them. I'll stick around if anyone wants to grab me privately. All right, thanks everybody.